my side for another teaching video. Today we're going to discuss respiratory auscultation and all the information you could get from it. So let's get started. So respiratory auscultation, this is simple. The first thing you need to do is just to look at your patient. Is he breathing normally? Is he putting more effort when he's breathing in or out? Or is it faster than normal? So these are simple information you can easily get just looking at them. Now, what's normal? The normal is you should, on a cycle, breathe for 1/3 in and breathe out for 2/3 of the same cycle. If there is a change, that means that there is an issue. It could be because of environmental condition, because it's too hot outside, because of stress, but it could be a sign of something pathological. When you put more effort, or your patient is putting more effort in breathing in, that's a sign of upper airway disease, obstruction or disease. So you need then to locate your physical examination to the upper airway, meaning everything that is extrathoracic, trachea, larynx, pharynx, mouth exam, and even sometimes sinus or nose exam as well. When your patient is breathing or putting more effort to breathe out, so when you have a push, when they are breathing out, expiratory push, then that means that the disease is in the chest, so lower pulmonary tract. So that means that could be either parenchymal disease, touching like the alveoli or interstitial disease, or that could be the bronchi as well. And then you will listen to the chest and help yourself by listening to the lung sounds. If there are any wheezes, that's most of the time signs of bronchial disease with then possible asthma, bronchitis, so that will open a differential that is completely different than a disease that does manifest with inspiratory dyspnea. If you listen to the chest and you can hear crackles, then your differential is not going to be the same either, and that will locate the disease to the alveolar space, and your differential will be then different. It could be fluid, so it could be cardiogenic, it could be because of electrocution, but that's not really common. It could be pus in the alveoli as well, and then it could be an infection. The last thing is there an abnormal breathing pattern, such paradoxical breathing? So what does that mean? That means that instead of your belly being sucked in when you breathe in, your belly is pushed out, and that's usually that's usually really consistent with pleural disease. So it could be pneumothorax, could be any kind of disease affecting the pleural space, fluid, such blood, such pus or air in the pleural space, or a mass. So all these things are actually really simple to observe and will help you a lot, because then you know exactly what test you need to order after. So is that a chest radiograph? Is that an upper airway radiograph? Is that a laryngeal exam? Is that an ultrasound to look for fluid in the chest? Do you need to listen to your heart? Do you need to do an ECG because are you suspicious of a heart disease? So that's why it's really important to do this first step really well, because then you know exactly what to do next, and you're not going to waste any of your time and money for the owners as well, or from the owners, to do another test that might not be required. For upper airway, so if you locate the disease to the upper airway, if you're unsure about if the pet is open mouth breathing or no, or breathing normally through the sinuses, you could use just slide and put it in front of one of the nostrils to do one at a time and see if there is any air going in and out, and that will be an indication of possible nasal disease or sinusal diseases. If you can hear or see flame in the mouth, hear crackles in the trachea, that could be an indication of abnormal amount of mucus, pus, anything there. If you can hear some wheezes, that can be a sign for a collapsing trachea. If you can hear, and then it depends on the breed as well, some obstructive upper airway obstructive disease, laryngeal disease, laryngeal paralysis, so this vibrating cartilage that does vibrate when they breathe in. Depending on the age, the breed, the condition of the patient, then it's something you will need to sedate the patient to be able to really assess for that. So when you listen to the chest, you could listen to the ventral part of the chest or the dorsal part of the chest. When you hear some abnormality, it's quite important to make a mental note of the location, because if it's dorsal that you can hear crackles, then that's less likely going to be consistent with an aspiration pneumonia. If you hear crackles in the cranial part of the, so the ventral part of the lung lobes, that's more consistent with a possible aspiration pneumonia. If it's on the right side and the area that does correspond to the middle lobe, right middle lobe, then same, it's more likely consistent with an aspiration pneumonia. If you hear crackles in the dorsal part of the lungs, then you will think more about a possible cardiac issue and a cardiogenic cause, or other cause, strangulation, electrocution, or something like that, or just a pneumonia by sepsis and not necessarily by aspiration. If you hear wheezes, same, usually it's not as specific, but depending on the area, you could also locate a disease to one of the lung lobe and potentially identify some obstructive disease, a mass or something else in the lungs. Thanks for watching this episode, and see you next time. We will discuss cardiac auscultation and same, the different implication and what you could get from your examination. Catch you next time!